We're going to start with Amrita Roy, Ms. Amrita Roy, who is in a PhD program. She's a candidate at the University of Calgary's Faculty of Medicine in the Population and Public Health program. Her doctoral research examines the determinants of depression in pregnant Aboriginal women. And today you're talking about paying attention to family of origin issues. That's not it? Okay.
Thank you. Thank you very much for the introduction. So my talk is actually Motherhood and Mental Health in the context of intergenerational trauma, reflections of pregnant Aboriginal women. Sure. Sorry. So I'm looking at motherhood and mental health in the context of in the context of intergenerational trauma and looking at pregnant Aboriginal women. So this is sort of spinning off a little bit from my dissertation research. And the learning objectives, I think, are in the course materials, but I'll start by talking a little bit about what intergenerational trauma is, and then go into some of the findings from the research that we're doing in Calgary, Alberta. So intergenerational trauma, it's also called historical trauma, collective trauma, multi-generational trauma. There's a few different names for it in the research literature. But where we see intergenerational trauma are in populations that have experienced long-term mass trauma. So things like colonization, slavery, or genocide. The theory actually started in regards to descendants of Holocaust survivors for World War II Holocaust, but it's been applied to other populations as well. And where the phenomenon is, or where the theory sort of started out, was in recognizing that even several generations after the occurrence of the traumatic events, or the original traumatic events, rates of disease or social problems, things like that, remain elevated. And so even generations afterwards, the trauma existed. And so that was what sort of spun off the research in this area. As a phenomenon, the symptoms of intergenerational trauma are maladaptive and social and behavioral patterns that are passed down through generations, and the pathways through which that transmission is believed to occur include impaired parenting. And what we see in intergenerational trauma are psychological problems and destructive behavior that are associated with maladaptive coping. We find that those are elevated in the populations that are impacted. So things like addictions, suicide, violence, as well as mental health issues. It's also of note that intergenerational trauma, although it's sort of rooted in historical events, is not just a historical phenomenon. There's sort of the historical grief, but it mingles with present-day sort of grief, anger, and trauma as well. And we're talking about populations that often do have higher rates of addiction, suicide, violence, poverty, social disparities, as well as things like racism and sexism. So there's a combination of the past and the present that really exacerbates the intergenerational continuation of the trauma. So the specific population that I'm going to be talking about today are Aboriginal peoples in Canada, although I will note that there's a lot of parallels with the Indigenous peoples of the United States, Australia, and New Zealand. Those four countries have very similar colonial histories and very sort of similar dynamics there with intergenerational trauma and health and social inequities. So in Canada, Aboriginal peoples include the First Nations, Métis, and Inuit groups of Canada. And these groups, relative to other Canadians, do experience higher rates of social inequities and poor physical and mental health. And it's important to note that those are connected to each other. And in public health, we talk a lot about the social determinants of health and how sort of the broader social context does drive health. And so the health disparities that are seen are very much connected to the social inequities that these populations face. And in the case of Indigenous populations, we sort of have colonization as the upstream driver of the social and therefore the health inequities. So it's all sort of connected in a pathway. So colonization in Canada, as well as the other three countries that I mentioned, it's sort of hard to summarize 500 years in one slide, but if I were to try to do that, you could say that colonization represented a large-scale loss of lives, land, culture, and identity, large-scale disruption of families and communities, oppression, subjugation, and I'll be talking about a couple of examples in a Canadian context, the residential school system, as well as the Sixties Scoop, in terms of very specific events of colonization. But again, after sort of centuries and centuries, what has resulted has been a lot of mass trauma and constant and unresolved grief. So to give the first example of colonization in Canada, it's the residential schools that I'm going to be talking about. So residential schools, they were in place from about the mid-1800s to the late 1990s, actually, was when the last one closed. They were church-run schools, but they were government funded, I think. And the explicit purpose of these schools was assimilation and destruction of Aboriginal cultures. Excuse me. So these schools taught that Aboriginal ways were shameful, they taught that Aboriginal ways were savage, the kids were taught to reject their ancestors or families, everything about their identity was basically, they were told to reject all of that. The conditions themselves at these schools were appalling, a lot of disease, a lot of malnutrition, a lot of mistreatment, including rampant physical, psychological, and sexual abuse. So a lot of very traumatic events occurred at these schools themselves. Apart from what the students went through, though, there were also the families and communities that were disrupted when these kids were taken by force from these families and communities. So there was a large-scale disruption at those levels, as well as what the kids themselves experienced. Many students died from the horrors that occurred in these schools, and those that did survive the school process left the schools dissociated from their traditional cultures, yet still not accepted by mainstream society, so they belong neither here nor there. They lack that basic sense of identity that is so important. They lack basic life skills, including the ability to form healthy relationships. If we think about where we learn that from our families, we learn that from our communities, and these kids were taken away from that and put into very traumatic circumstances. So those basic life skills, including relationship skills, were just not there. And of course, there was a lot of trauma from the mistreatment and the abuse that went on at the schools. So the second example of colonization in Canada that I'm going to give is the Sixties Scoop. So by the 1960s, all of the last residential schools in Canada closed in the 1990s. By the 1960s, they were sort of falling out of favor. And what happened in their place was basically the child welfare agency. And the period between the 1960s and the 1980s in Canada was known as the Sixties Scoop. And what we had sort of was pretty much this mass indiscriminate removal of Aboriginal children from their families, from their communities, and they were put into foster care or adoptive homes in non-Aboriginal homes, usually very far from their communities. In some cases, they were shipped across the border into the United States. And so the connection there was, again, completely severed. So in many ways, it was very much a parallel to the residential school system. And there were similar effects from as the residential school system. So a lot of disruption of families, communities. The kids were dissociated from their culture, and yet they still were not included in the mainstream society either. There was a lot of racism, there still is as well. There were a lot of cases of abuse by adoptive or foster parents. And again, these kids lacked a sense of identity, stability, and belonging, which became particularly hard when they hit adolescence. And so there was a lot of trauma. So a lot of parallels with the residential school system as the Sixties Scoop. So if I were to sort of summarize what intergenerational trauma looks like in Aboriginal people, it would basically be to think back to colonization and think of it as centuries of traumatic events, one after the other after another. Those were just two sort of concrete events that I described, but it was lots of events. And so what happened was that process has unleashed a lot of mass trauma and a lot of unresolved grief that sort of has been continuing. And that has spurned a lot of maladaptive coping strategies. So we know that in Aboriginal peoples of Canada, as well as other Indigenous groups, in other sort of colonized countries, we do see higher rates of things like alcohol and drug use, criminal activity, violence, including domestic violence, as well as self-harm and suicide. And those are sort of maladaptive coping strategies to the unresolved grief and the mass trauma that has occurred through the events of colonization. And these coping strategies and these behaviors then get passed on through two subsequent generations through the impaired parenting that results. It's also important to note that intergenerational trauma is a large-scale phenomenon. So we see the impacts on the health and well-being at the individual level, but it is also very apparent at the population level. And so population health is my field, and so if you think about measures of like incidence and prevalence and those type of population level numbers, this is sort of the intergenerational trauma is really driving those numbers in terms of why those numbers are higher for things like mental health problems and so forth in the Indigenous community. So moving on now to pregnant and parenting Aboriginal populations of today. For the most part, pregnant and parenting Aboriginal individuals will have been too young to have been in the residential school system. They may or may not have been in the 60s school system, depending on how old they are. But for the most part, many of them will have caregivers, parents, relatives, other people in their lives who were impacted by those systems. And so, in turn, they have been impacted by their caregivers' traumatic experiences. And so as these individuals now go on to become parents themselves, that cycle of intergenerational trauma risks continuation unless it is broken. So it is a very critical point of intervention. This leads me to a study that we are doing now in Calgary, Alberta. It's called the Voices and Faces study, but it's a constructivist grounded theory study that we're doing in partnership with the communities, the local Aboriginal communities in the Calgary area. The goal of the study is to understand the determinants of prenatal depression. And we are using personal interviews with pregnant Aboriginal women, as well as personal interviews with health and social service professionals in the Calgary area who work with pregnant Aboriginal women. And we're also doing focus groups with various stakeholders as well.
What do you define as stakeholders?
So we've got government, we've got a representative from the Alberta government, we've got various service provider managers and so forth that we interview just to get more of the service and the policy sort of side of things. And then, of course, we're talking to the women themselves in personal interviews. So for today's presentation, I'm actually just going to focus on a few quotes from what the women had to say. So we interviewed 13 women. And one of the things that, or a few of the things that really struck us in the context of intergenerational trauma is that pretty much all of the women had at least one known relative that was in a residential school. Sometimes it was their mother, father, grandmother, aunt, uncle. Some even had older siblings. So it was very much a big part of their lives. Almost all had either a personal or a family history in the child welfare system. And most of them spoke to us of cycles of substance abuse, violence, and neglect in their families. And some were very articulate in the way that they were able to link those experiences with their personal mental health. And some were very articulate too in talking about how they use substance abuse as a coping mechanism to all of that stuff that was going on in their homes and in their communities. So I have a quote here that sort of illustrates that. So this is a pregnant mom who's saying, "My mom was never around for me and my siblings. Her mom, my grandma, was in residential school, and she said what she got out of it was she didn't know how to love, how to show affection. She wasn't there for none of her kids. All of my uncles are in and out of jail through their whole lives. My aunties drink a lot, and my mom smokes weed. I was also following in that pattern of drinking and not caring." So this quote really sort of encapsulates that intergenerational transmission of the trauma and of the maladaptive coping mechanisms for trauma. The other thing that we noted in the data was that women were, now that they were pregnant, they were really reflecting about motherhood in light of their complex relationships with their own mothers. Because again, a lot of these mothers were in residential schools, and so that relationship was very volatile and very complex. And so now that these women themselves were pregnant, they were really reflecting on that. So this woman said to us, "Pregnancy has been an emotional time for me. For a long time, I really hated my mom and was mad at her. But now I have a better understanding of what she experienced in residential school. You have to be empathetic and be the bigger person and end the cycle of abuse." So there was a lot of reflection going on about what it means to be a mother in the context of all this trauma. The other thing that we noted, and it's sort of some room for optimism, I guess, is that pregnancy seemed to motivate a lot of positive life changes, both in terms of, I guess, sort of behavioral changes like better diet, that type of stuff, better taking care of themselves, but also more sort of changes in perspective as well. So we have a quote from one mom who said, "My mom, because she was in residential school, didn't know how to be a mom. I feel really blessed that I can now be a mother and do things differently and be present in my baby's life. My pregnancy has been a healing process for me." So we found that very poignant, that pregnancy was really this sort of life-changing event for a lot of these women. Which leads to, I guess, a take-home message that I'd like to point out, and that is that pregnancy is a powerful intervention point. for intergenerational trauma and for health and social issues more broadly. As we saw with the last quote, pregnancy may motivate positive life changes, it may motivate changes in attitude, and on a more pragmatic level, it leads to contact with services in a much more immediate way than a non-pregnant population. So there's both sort of the opportunity as, both in terms of that direct access and also in terms of some of the more motivational changes that come across. So pregnancy may be a meaningful opportunity for both clinical and public health interventions. And so in terms of then maybe solidifying the connection a bit between intergenerational trauma and mental health, it's fair to say that understanding intergenerational trauma is critical for both individual level and population level interventions. And the reason for that being is that, and depending on your discipline, you're going to use a different word of the ones that I've sort of listed up here, but if we think about pathways leading to mental health, in Indigenous communities and Aboriginal populations, intergenerational trauma is a distal, upstream, root, underlying cause, whatever word your discipline uses, that eventually leads to mental health along that pathway. So we're talking about primary prevention. You've got to really aim up in that pathway and really nip it in the bud. And so intergenerational trauma is very important for planning services and planning programs and planning policies for this population. In terms of a little bit about what that would look like, because colonization represented sort of a severance with traditional culture, including culture as a healing practice, one of the ways in which the impact of colonization can be reversed is to sort of reconnect, or help Aboriginal communities reconnect with that cultural piece and to draw on that as a tool for healing. And so bringing in more culturally appropriate services is a powerful way to counter intergenerational trauma. The other thing that's important to note when we think about intergenerational trauma and service provision is this idea of cultural safety. So cultural safety, it goes beyond mere cultural sensitivity to actually querying questions of power in the relationship between service providers and patients or clients. And so given that colonization represented sort of very blatant oppression and subjugation, it's really important that services be careful not to sort of recreate that dynamic in the service provision. So cultural safety is all about making sure that clients and patients can feel respected and empowered in their relationships with service providers. So in conclusion, intergenerational trauma is very important to understanding mental health in Aboriginal individuals, families, and communities. So again, individual level as well as population level understandings, and therefore taking that understanding and applying it in interventions. And what our research has suggested, and others have other research has suggested this as well, is that pregnancy is a critical point of intervention to break this cycle of intergenerational trauma. And so I do, in the conference syllabus document, I provided a recommended readings list, so please feel free to look through that. And thank you very much for listening to my talk. And I'm happy to exactly 10 minutes, so I'm happy to answer any questions.
Can you talk about more specific ways that you provide, or that for recommendations for cultural safety as opposed to just cultural sensitivity?
Right. Yeah. So cultural safety, as I said, was the main thing is looking at that power dynamic. And so there's the recommendation that's given in the literature is that it really comes down to giving adequate training to service providers so that they can be aware of ways in which that power dynamic can be sort of addressed I guess addressed would probably be the best word, just to overcome that power dynamic so that patients are feeling that they are in a position of power. And so I guess the main thing there is just reflexivity on the part of the service providers about those issues of power and making sure that they do even little things like even just language used, things like that, so that they're not, when we talk about the biomedical model and stuff like that, and about how that really pathologizes a lot of these issues, or it renders a lot of social issues into biological issues without looking at the broader social issues. So just bringing that perspective into the sort of provision relationship. And there are specific training courses, I believe, that some agencies do offer for cultural safety. So just making sure that that type of training is available for service providers is important.
I would say, also starting with the parents' goals, really validating the parents' goals helpful.
Absolutely, yeah.
I was wondering about your sample. Can you tell us more about some of the demographics around that?
Sure. Yeah, absolutely. So this is qualitative research, and so an important distinction I guess to make right off the bat is that with qualitative research, it's different than quantitative methods, where you're looking to recruit usually a large sample size, and you're looking to usually recruit a representative sample for your demographic and things like that. In our case, we did grounded theory, so we were interested in certain theoretical constructs that we sampled for. But we had 13 women, and we recruited them through our partner agencies. So we had 5 clinical and social service agencies, as well as other recruitment sites as well. So they were all from service providing agencies that we recruited them from. So we had quite a few that were experiencing housing insecurity, things like that, and that's just in part it's a convenient sampling issue because a lot of our agencies were housing agencies. We did have some women, though, were quite financially secure as well. We were, for our theoretical sampling, we made sure that we got a good mix between those who were more socioeconomically, like sort of lower socioeconomic status versus those with higher socioeconomic status. So we had everything from sort of, no high school education right down to a university degree. We had sort of a full range. Same thing with our income, sort of on disability welfare, all the way right up to sort of well off financially. In terms of mental health diagnoses, we actually had, as part of our surveys, we did the Edinburgh Postnatal Depression Scale just to see sort of where women were at in terms of depressive symptoms, and I think we found more than half rated at a score that might indicate major depression. However, very few actually had ever been told by a healthcare provider that they might have mental health issues, which we thought was very interesting because these are all women that are in the service system, because that's how we recruited them. And yet, so few of these women have actually received any treatment for mental health issues that were probably there. I mean, we weren't in a position to diagnose, but from the scale screening, we figured that there was probably some issues there. A lot of these women were involved in the child welfare system, that came up a lot in terms of really feeling beaten down by the child welfare system and really feeling like the child welfare system was against them, and so which was interesting in light of the fact that so many of these women probably had mental health issues but were not diagnosed, and so they were not getting the support that they needed to overcome their mental health issues to be able to get their kids back, and so we heard a lot of that. But
What age were they?
yeah, they were pretty young actually. We cut it off at 18 just for the sake of research ethics and all that kind of stuff. We decided to keep my life simple as a PhD student and not get into under 18. But they were pretty young, and that's consistent with Aboriginal. Aboriginal women do start to have babies a little bit sooner than I think the other segments of the population. So I think our youngest was 18, and then I think our oldest was, I want to say early 30s, and most were sort of early to mid 20s.
In first pregnancy?
We got a mix. Some were first pregnancy, and some were second, third, fourth. So.
And what about family constitution? Was there single parents or did you have?
A great question, yeah. So for the most part, actually, they were single parents. We did have some who were married. We had some who were common law. We had a lot of single parents as well. We did have, unfortunately, a lot of women that were escaping domestic violence type situations. And so that came at a lot. The lack of support from the partner did come